All right, it's noon, so I think we're going to get started. I believe, do you guys still have people coming in? I know you guys are all on mute currently.
We have a couple people that'll be late down here in Rolla.
Okay. Do you want us to wait a few minutes, or you just want them to roll in as we begin?
They'll roll in as you begin.
Okay, sounds good. Thank you.
Yeah, we're set here in Southwest.
Okay, perfect. Thank you. All right, so we're going to go ahead and get started. As people come in, obviously catch them up to speed. But my name is Jill Fitzgerald, and I am an assistant professor at St. Louis University. I'm also a physical therapist and a geriatric certified specialist in physical therapy. Today with me is Dr. Kelly Hawthorne as well. Kelly is also an assistant professor at St. Louis University in the program of physical therapy and is also a geriatric certified specialist. I will be beginning I will start the presentation, and then you will see us kind of in the middle switch over, and Kelly will take over the second half of the presentation. Today we're going to focus on the musculoskeletal changes with aging, and we'll talk about, we'll just do a review of the anatomy and physiology and the changes that you may see with aging. From there, we'll also look at neuro changes, for we can't ignore the neural system when we talk about a musculoskeletal. And then we will go into the effects of the neuromuscular skeletal changing. And then from there, we'll go into a question and answer. So that's the format we'll be moving forward today. Can everybody see our presentation? You can give me a thumbs up, that'd be great.
Kirksville is not connected yet.
Okay. It looks like, oh, thank you. It looks like Kirksville's not connected, so hopefully they'll connect soon.
We're here. We're here.
Oh, perfect.
Yep. Sorry, we just kind of got things hooked up. So.
Okay, great. Can you guys see our presentation as well?
Yes.
Okay. Thank you. All right, then we're going to go ahead and get started. Before we get started, we do want to thank AHEC for having us come in and talk about something that we are passionate about, and again, very close to us as being physical therapists working in the geriatric population. All right, so we talked a little bit about our objectives and what we'll be doing moving forward. To start, I just want to review and talk a little bit about the different theories of aging. So as we know, and as this table will spell out for you, there are many theories of aging, and we are really focusing on the physical changes and the biological changes, although I don't think that there is one specific theory that we can point to. Otherwise, we would probably have a lot of people who are trying to change the way that we age or stop aging. So we know that it is complex, aging is complex, but this table just summarizes for you the different theories that there are currently on aging. So to start with some of the changes in the musculoskeletal system with age, we need to talk about strength. We also need to talk about power, and we need to talk about mass. So when we talk about the muscle in and of itself, we know that muscles create a force that then creates strength. So as we may assume, muscle weakness does occur as you age, and believe it or not, muscle weakness occurs at a rate of 1 to 5% after the age of 30. So all of you who are under the age of 30, get all your strength right now. All of you who are over the age of 30 know that we're starting to decline, so we need to continue to exercise to keep what we have. Power, when we talk about power, just to go back and remind ourselves what power is, it's the amount of force produced over a period of time. So we are looking at how fast a certain force is produced. It is known that at the age of 60, power decreases more rapidly with a rate of about 3 to 5% annually. So as you can see in all the older adults that you may see, the ability to move and react quicker in the older adults has, the time to do so has increased, or they don't react as quickly as we might think. So when we think about falls, when we think about maneuvering over obstacles, they may not be able to react as quickly and therefore produce a fall. We also want to look at mass and the actual muscle mass. Muscle mass obviously does decrease as well with age. It's usually at a rate of about 4 to 6% per decade, and it starts sooner with females than it does with males. So As we continue to review the different changes in the musculoskeletal system, typically things, reaction time is going to increase, muscle mass is going to decrease, things don't act as quickly, or they don't stay as bulky as we may like. This study here is the Framingham study, and the basis of this study really is to show that muscle strength does decrease with increased age. So they just looked at a variety of different age groups of participants and asked them to lift the 10 pounds, and you'll see the study says here that 65% could not lift between the ages of 75 to 84, as opposed to 55 to 64, it was only 40%. So it just proves some of the aging changes that we just talked about. We're going to step back a little bit and look at some of the anatomy of the muscle and the muscle spindle. So you can see when we talk about muscle strength loss, if we look at the specific spindle and break it down all the way, we might see that the decreased strength is due to a decreased ability for the muscle to contract. And you can see that sometimes there's increased fat in the replacing some of the muscle, or an increase in connective tissue. Another reason we might see a decrease in strength would be because of inactivity. So if the patient or the client is not moving as much, which tends to happen with age, we can see a decrease in muscle strength. As again, review, we know that there are two types of muscle fibers. We have the fast twitch type 2 and the slow twitch type 1. We know that with the aging adult, type 2 muscle fibers are reduced quicker with age. So therefore, the fast twitch, again, going back to the ability to generate a muscle contraction quickly. So you will see that while there is loss in both, type 2 tend to be you tend to lose type 2 quicker than type 1 with age. Which leads us to the idea of sarcopenia. Hopefully this term is not new to you, but just to define it, it's loss of muscle tissue as a natural part of the aging process. Usually you see a loss of muscle mass, strength, and endurance. And you will see that your max strength is in your 20s and 30s. And atrophy does not fully explain the loss in older adults, but we do see that there is sarcopenia. Currently, Dr. Hawthorne and I are in a grant here at St. Louis University. It's a HRSA grant with Dr. Morley and his team. And part of our grant is to go ahead and screen for sarcopenia. So this slide here is the rapid geriatric assessment, which is an assessment that Dr. Morley has discovered with others and put forth as a good assessment for any geriatric population. And the grant that we are currently working on, we are working in the state of Missouri in order to screen as many older adults as we can and then try to get intervention in different areas of the state in order to combat some of these issues. But you can see in the top right corner, you can see that there's the screen for sarcopenia. And so you can see that you just score them. And on strength, assistance in walking, rise from chair, climb from stairs, and falls. And it's usually a subjective, it's just asking these questions. Other things that are on there would be the frailty, also looking at nutritional assessment, and the rapid cognitive screen. So over the past year, we have screened quite a few in the state of Missouri through healthcare workers and also through those here at SLU, training those in different areas of Missouri and through our students. And Kelly and I are currently working on putting together a community exercise program to help combat sarcopenia and increase strength in the community dwelling older adult. So hopefully this screen is available. It is available through the internet. It is free. It is something that has been validated. And so moving forward, we hope that you can take a look at this screen and hopefully utilize it with your older adults and to be able to identify some of these issues and prevent falls, prevent sarcopenia, and just increase the quality of life for the older adults. We talked a little bit about the changes in the musculoskeletal system, but we all know that if you talk about the musculoskeletal system, you also have to bring in the neurological side of things because it is all connected. So we do want to touch a little bit on what are the changes in the peripheral nervous system and the changes that you may have with age, the anatomical changes that you may have with age can affect reaction time, can also affect nerve conduction velocity, and can also affect reflexes. So if we, again, go back to the anatomy of the neuromuscular junction here, you can see that strength of loss may be an inability for the signal to get from the brain, the CNS, down to the muscle in order to contract. And we know at this junction what happens is that there is a release of acetylcholine at this junction in order for the signal to travel across and contract the muscles. So if there is a decreased amount of acetylcholine, you will probably have a decrease in the transmission of the pulse, which would increase somebody's reaction time. So again, we're looking right at the junction, we're looking at the acetylcholine, the amount that's there, and being able to quickly transfer that pulse over to the muscle to, again, quickly the muscle to respond, to react. Decrease in acetylcholine, again, is going to cause an increase in reaction time. If we look again at anatomy, as we've pulled these out, you can see that if you look at the number and the length of the nerve cells and the number of dendrites, which are the receptors, those do decrease with age. So as they decrease, or if there's an accumulation of fat in the area, you can get a decreased nerve conduction velocity. So again, if there's not as many or not as receptors, or there's something blocking it, such as fat, that you will see that there is an inability for the signal to cross at a fast speed or a normal speed. So you might see a decrease in the velocity. This is just to bring you back. Hopefully you've seen this before. If not, it's a good referral source. If you look at the normal muscle contraction, you can see that when a stimulus is applied, there is a short latent period, and then there's a contraction phase, a relaxation phase. And again, it's a tension time curve. So the tension will increase as time increases over a 0.1 second in these different phases. And with a normal muscle contraction, it's a quick muscle contraction, a normal curve. When you go to the older adult, you can see that the latency period is going to be increased a little bit based upon the changes that we just talked about. And then you'll have a contraction, and the relaxation phase may take a little bit longer too. So not only may it take a little bit longer for the muscle to react and contract, but it also may take a little bit longer for it to relax. And this is just repeating exactly what I just said. When we talk about reflexes, so again, just going along with kind of the theme that we've been talking about, you're going to need more sensory input in order to get the reflex to occur. There is less conduction or less at the spinal cord or cerebral cortex, and there's usually a decrease in the efferent conduction, so the signal going out. So again, it's just going to take a little bit longer for reflexes to happen in the older adult due to these changes. So here we just look at two older adults still enjoying life based even upon all the changes that we just talked about. You know, you can look at this picture, analyze a little bit as we move forward, and we'll talk about the aging skeletal system and just look at the posture, look at the her fingers, look at the facial features, those type of things. So lastly, we want to talk about the skeletal system. So as the client or patient gets older, you can see that there's a continual process of absorption and reabsorption, but your peak bone mass is shown actually in late adolescence. So probably around college time, you head off to college, you're at your peak bone mass. And so not saying that we can't continue to take in calcium, but the peak bone mass that you're going to have is at a really early age. And skeletal mass is usually higher in men than women. Just as a note, we always talk about osteoporosis. Osteoporosis is actually pathological. It's not a normal aging change. But as we look at the long bone, you can see that the quality of bone decreases. There's a decrease in bone stiffness, in bone strength, and in bone toughness. So it just is an overall quality of the bone diminishes. You'll see that as the bones begin to weaken, the outer shell of the bone starts to get thinner. And then as you look into the vertebrae, you will see that there is a decline in the cortical thickness of the vertebrae, and it disrupts the trabecular work. Okay, so you'll see that the risk of vertebral fractures is higher in the spine just based upon aging changes. You can see some skeletal changes, some typical skeletal changes that we see is the hallux valgus, or as we usually refer to them as bunions, but you can see them in this picture here. We must also talk about the joints in aging. So we can't just talk about the skeletal system without talking about the joints. So we know that, again, there's a decrease in flexibility to the connective tissue changes, and there's a decrease in water content. So the tendons, ligaments, they're less compliant, they're less strong, they're weaker, so they're more susceptible to injury. The cartilage becomes less compliant because of decrease in the water. The osteophytes frequently occur on the head of the long bones, just because of aging changes, probably due to Wolff's Law as well. The stress that you put on the bones is it increases bone formation. So they're a little less resilient, and you'll see a lot of changes in the tendons, for instance, rotator cuff. You'll see a lot of OA. By age 60, it's known that about 80% have some type of OA. If you want to see a good example of this, you can look at the arches of the foot. You can see as the client or patient gets older that the arches in the foot tend to diminish or become more flat foot or splayed foot because of the connective tissue and the inability to hold strong the arch up in that position. This is just a zoom view of a joint here and looking at the articular changes that you may see and knowing that the osteophytes tend to gather in this area. I'm going to switch it over to my colleague, Dr. Kelly Hawthorne, now to talk about the effects of the neuromuscular skeletal system. If we want to take a moment now to maybe ask any questions about just the anatomy and physiology and the basic changes in aging, if you guys want to either unmute yourself and ask the question, you can definitely do so, or you can type it in the chat box. We do have our chat box open. So I'll give you a few minutes as we kind of switch over.
Give me a minute, just in case.
All right, well, it doesn't seem like anybody has any questions at this time. If you think of any, you can go ahead and type them in the chat box and we can answer them at the end. I will be here through the whole presentation as well, and Kelly and I can feed both of those questions need be.
Hi, everyone. My name's Kelly Hawthorne. As Jill mentioned, thank you, AHEC, for inviting us. So you just had a review of the neuromusculoskeletal changes that happen with age. And my job is to talk to you about the effects of those on function of the older adult. So we know with the changes in the muscle and in the joint that the ranges of motion, both active and passive range of motion in specific joints decrease with age. So for example, this is a chart, and I don't know if you can see where my cursor is, but ankle dorsiflexion, or the ability to lift the foot up. In someone younger, normal is considered about 20 degrees range of motion. But as one ages, that decreases in half. So normal dorsiflexion range of motion in an older adult is about 10 degrees. And really, these changes in range of motion at the joint are cumulative. This is an example of an older adult that has hip flexor tightness. And what that leads to is not only flexion then at the hip, but flexion at the knee and at the ankle. Now, someone that's older may have tightness in the joint at the hip flexor, or they may have weakness in the extensor muscles at the hip. And either one of those can lead to this chain reaction of an ultimately flexed posture of the lower extremities. And this is just a picture of a typical older adult's posture from the waist up. You can see the forward head, the increase in kyphosis, the forward rounded shoulders, even the loss of the normal lumbar curve is present with many older adults as they age due to these changes in the systems. And this is just another representation, but looking up the chain. Hip flexion tightness, kind of affecting the whole body. And why do we really worry about this? And it's because what can happen is that an older adult may end up limiting their activity due to these changes. So a decrease in flexibility can, at the joint level, whether it's due to joint changes or muscle changes, can lead to an increased risk of falls. And then we know once someone's had a fall that they're more likely to be fearful of falling. A decrease in muscle strength can lead to a decrease in gait speed. And then also balance, which has many components to it, but overall the effect is the same. And then finally, as we mentioned, we hope that this doesn't lead to a self-restriction in activity, but oftentimes it does. There is some good news that we have for you today, and that is that, oh, I'm jumping ahead. We're still on bad news. A decrease in muscle strength makes functional things, like those things listed here, which I won't read line for line, but it makes these functional things more difficult. Everyday things that our older adults need to be able to do become more challenging. We also know that it takes more effort at the muscle level for an older adult to perform everyday activities like getting up from a chair. And we know that lower extremity strength is a predictor of an older adult that may require institutionalization, which is something we hope to prevent for our older adult patients. And this is just a graphic representation of that. You can see on the bottom someone that is younger versus someone that's older, and what percentage of a maximum voluntary contraction at the muscle level it takes to rise from a chair. And someone young and healthy, it takes anywhere from 50 to 75% of their effort. But for an older adult, we are at the maximum effort required at the muscle level to do everyday functional things. So as a physical therapist, it is obvious with these neuromusculoskeletal changes that we need to do an assessment at the specific level. We look a lot at the hips from a strength and range of motion standpoint. But then there are also many other assessments that we need to include. We know grip strength, which our OT colleagues help us with often, is consistently associated with a greater likelihood of mortality, the development of disability, and an increased risk of complications or the requirement for a prolonged hospital stay. So we need to make sure that we're assessing our older adults, not just at the muscle or joint level for the changes that we know can occur with age, but also these other things. So grip strength, gait speed, posture we talked about, reflexes, balance, function, including just everyday tasks. Obviously, we need to understand the patient's medications and those potential interactions on their function. As physical therapists, we have to be assessing our older adults' feet. As Dr. Fitzgerald alluded to, there's many changes that occur with age. Obviously, sensation. And then included in that rapid geriatric assessment was a question about falls. And we need to make sure that we are asking our older adults about the frequency with which they fall. And often it actually takes some skill to do that and actually get the information that you're looking for. Okay, now to the good part, or the positive part, is that there are benefits for the older adult in strength and flexibility training. So we know that strength exercises can build muscle. They can offset the loss in muscle mass that typically happens with age. And we can even help to improve bone health and decrease the risk for osteoporosis. So if we do strengthening exercises, we can increase muscle fiber size and that can really begin at any age. Also, with flexibility or stretching exercises, we can increase the flexibility, both the active and passive range of motion for our older adults. We can help to slow some of the age-related changes that happen in the neuromusculoskeletal system. Actually, strength training can improve glucose uptake for our older adults that are diabetic or pre-diabetic. And obviously, we know that increased strength equals increased function. And Dr. Morley, who we're on the grant with, definitely is a strong believer in strength training with older adults at any age. The next two slides kind of go together. And what this is really a document from the geriatric section of the American Physical Therapy Association that breaks exercise for older adults into 4 categories: muscle performance, aerobic capacity, flexibility, and then balance. And this is actually meant to be a chart that helps to guide how we as physical therapists dose appropriately our exercise for older adults. And really, I wouldn't expect that you would, interpret this entire chart, but the take home from this is that we have some literature that's available that guides us as geriatric clinical specialists, physical therapists, to dose appropriately exercises for individuals based on our individual assessment of them. Strength training is definitely an important component. The muscle performance, that would be the category that falls under. But we also look at cardiovascular pulmonary endurance, and then all of the systems that contribute to balance and falls as well. So individual physical therapy assessment and intervention is preferred. Now, on the grant for the rapid geriatric assessment that Jill and I are included on, we have been charged with coming up with a group strengthening exercise program that can be implemented at the community level for our older adult clients. So that's kind of second best, if you will, to an individual assessment and intervention for an older adult. And this chart supports that. I did want to spend a little bit of time, and we've got plenty of time, looking at a case and then having you apply those principles of exercise to a specific patient. So I'll just give you a minute to read this case. Let me know if you cannot see it, but I'll just give you a minute to read the case of Bradford. Okay, and then it looks like most of you are in group settings that I can see. I want you to turn to your neighbor and attempt to answer these questions. So what is considered normal aging, and what would you consider pathological in what you read about Bradford? What's the impact of his comorbidities and medications potentially on his function? And then using that chart, which I'll post when I'm done reading this slide, what would be 3 activities or exercises you would recommend for him? And specifically focusing on strength or muscle performance. So why don't we'll take about 4 minutes if you pair up with someone next to you and try to answer these questions related to Bradford. Is there a way to split this screen to have 2 things?
Bit of PowerPoint and see.
Okay, so thinking about the case of Bradford and our goal to improve his strength to impact his function, I'll have you guys take yourselves off of mute, or someone in the room is welcome to add to the chat. But pick out some of the things that differentiate with Bradford, normal aging, and then things that you would consider impairments from pathologies. So I'm not hearing any. I can't tell if you guys have taken yourselves off mute. It looks like somebody is typing. Why don't we just take one answer from each site? So should we start with Kirksville?
Okay, go ahead.
Okay, I can hear you. So thinking about the case of Bradford, what would you contribute to just being normal changes that happen with age, and then something that you think is pathologic?
Decreased endurance is bad news. Been a gold medalist swimmer.
Decreased endurance is bad news in a gold medalist swimmer? Yes. And do you think his fatigue is just normal age-related kinds of fatigue, or do you think that is due to his pathology?
That sounds pathological.
More iatrogenic than pathological.
Yeah.
Yeah, definitely pathological. I see we also have a comment that his balance is off and that is being contributed to his chemotherapy. And actually, we know that his balance being off can be from the changes in the joint and the muscle that happen with age. And he probably has kind of an extra deficit in this area from the side effects of the chemotherapy. And then who did we miss? Southwest Missouri?
Okay, so someone from our group noticed that, of course, he's got chemo on board. He's also taking NSAIDs. The combo is going to be ototoxic, so some of his balance could be coming from that as well. So in addition to his strength training, we've also got to get him off some of the toxic meds that aren't necessary for his cancer treatment.
Yes, if possible. Good idea.
Sorry to say the obvious.
Oh, that's okay. All right, and then someone else is still typing, but I'm just going to go ahead and move ahead. So, and I guess we kind of addressed the second question, looking at his comorbidities and medications and how those are affecting his function. So let's skip ahead to the last question then, talking about strength training exercises you may prescribe. I also don't know the makeup of the room. What professions are in the room? Are you all med students?
Yep, you're stuck with med students, sorry.
We also have some residents.
And some residents, okay. So let me phrase it this way. Other than recommending that your patient be evaluated and treated by a physical therapist, hopefully a geriatric clinical specialist, what recommendations would you give the patient from an activity or exercise standpoint?
Sit to stand training.
Sit to stand training?
Yes.
Was that the comment? Yes. Okay.
You need to follow
Possibly.
PT, obviously.
Yes, that's a great idea, contacting the physical therapist. The idea of sit to stand training is a good one. It's functional, would help to build muscle. With his OA in his knees, he may or may not be able to do that without causing some pain. So thinking of other ways to strengthen his lower extremities, we'd probably look at from a PT perspective. What's one more? Some other recommendation you would give this patient?
OMM to help any muscle imbalances.
I'm sorry, I heard somebody talking about, I couldn't hear what you said.
OMM to help with any muscle imbalances or muscle spasms.
See if he has any muscle imbalances or muscle spasms.
OMM.
Osteopathic manipulation.
Did you catch it? No, I'm sorry, I can't hear you on my end.
OMM.
Osteopathic manipulative medicine
Oh, okay.
and better nutrition. For his cachexia, he almost certainly has.
Okay, so you're thinking of some other things that maybe the patient needs or needs to be referred to from a more holistic standpoint for his overall function and health.
Right. Can we ask you, tell us a little more about what you do specifically for him, postural muscles. What does a PT do in this situation?
That's a good one. I'll take it first and I'll let Jill add to that. You know, one of the things I think about for this particular patient is the possibility of getting him in an aquatic setting. He obviously is a swimmer, so he's comfortable in that environment, and it would unload his lower extremity joints at least. He obviously needs strengthening in the lower extremities and then some balance training. And then I also think that we probably need to also work on posture, some of those extensor muscles. So we would be specific in our eval and our prescription, but looking at maybe scapular retraction or hip extension, and those things would help with his function. The idea of getting out and getting up off the floor, but it'd be in an environment that would be motivating for him since he is a swimmer.
I obviously agree with Kelly's assessment, but would also might add that obviously look at the other factors going in and work interprofessionally with physicians or nutrition, and then also make sure that he has an exercise regimen that he can do when he is when he's receiving chemo and when he's not. So you know, maybe a higher level or a lower level in his abilities at that time, and when is the appropriate time to rest as well. So I think those are important concepts to bring in, but definitely would focus on the same areas that Kelly had mentioned, and again, thinking of a motivating environment for him.
Thank you. Thanks for that.
Mm-hmm.
Which I think probably we're leading into the Q&A portion of the presentation. So we'll go ahead and field your questions before we cut you all loose. So any questions for physical therapists that are geriatric clinical specialists? And you can go ahead and unmute and ask the question, or if you want to type it, that's fine too.
I'm sorry to talk too much. I have one more for you. From a PT standpoint, at what point do you think you don't need to follow him anymore? Where do you feel like a patient like this is stable to proceed on their training on their own? What is there a specific milestone you're looking for?
From a get-go, I would probably look at some type of outcome measures as well. So, you know, one thing I would probably look at is fear of falling and where his fear of falling is. Also, his quality of living and in his assessment of his abilities, I think, is important. But also, you know, just doing a normal test and measures, making sure functionally that he is his posture looks better, or he is able to perform postural exercises independently without any cueing. Also, you know, that he is able to recite or be able to perform his exercise regimen on his own and knows increase in intensity if need be. Also look at, again, his function. Is he able to get up the floor with ease? Is he able to go from sit to stand with ease? Can we see when he's competing or when he's not competing that his endurance may, what measure would we use to look at his endurance, whether it's rate of perceived exertion or looking at a different test and measure to do so. So I think I would probably obviously do some baseline measurements in all of those areas when it comes to strength, when it comes to endurance, when it comes to flexibility, and when it comes to some of the more subjective outcome measures, and then when he gets to a point where he has increased in those measures, is independent in his activity and shows increased function, would be the time that I would be able to let him move on to an independent exercise program.
Yeah, I would add to that, definitely looking at some outcome measures so we have something to assess him against. But he is scheduled to have surgery in a month, and I would want to follow him through the surgery. So I may be able to decrease the frequency of my visits with him between now and then, but I definitely would want to see him after the surgery, and if we had those outcome assessments, see if he's lost any function in that time. And then after the surgery, kind of decide if he is kind of improving and things are stabilizing, then I would feel more comfortable maybe getting him into some sort of group exercise. But if he regresses, he's going to need physical therapy even more. So I would really want to at least hold on to him through his surgery for another month. We've got time, so we'll take maybe 2 more questions.
I saw that your recommendations for strength training are based on a percentage of 1 rep max. And I would like to know, with your elderly patients who are debilitated, are you actually getting a 1 rep max? And if you are you estimating a 1 rep max?
So that's a very good question. And, can you truly determine a 1 rep max with an older adult, which is challenging? We have some tricks up our sleeves, I would say, on ways to attempt to do this. But, this is also very specific to one muscle rather than a muscle group. And it can be different if you're looking at a functional activity versus a specific muscle itself. So we would attempt to determine a 1 rep max and then have him perform his exercises depending on if we're looking for more strength and mass or if we're looking for more endurance at the muscle level, either 40 to 60 or 60 to 80% of that 1 rep max. But we would attempt to determine that with our older adults. And we know, from research in our field that many physical therapists actually underdose all exercise, including strength training for older adults. So we would try not to shy away from really determining what that is. I don't know if you'd add anything to that.
Yeah, I agree with Kelly's assessment there. And to note that a 1 rep max, when you're looking at a 1 rep max with anybody, you have to worry about muscle fatigue too. So we, as Kelly said, we have some ways to determine 1 rep max, but it may take 1 or 2 times to determine exactly where they're at. But as studies do show that a 1 rep max, even in the older adult, depending on what you're looking for, anywhere between the 40 and 80 range, depending on your goal, is still sufficient for the older adult. It's just making sure that you get the right amount of weight. We tend to, again, underdose for older adults because we see them, I guess, at face value and say, oh, they can't lift that, when in all actuality, if we're looking for strength gain, that is exactly what you should be doing. Good question.
And we'll take 1 more question.
If you guys don't have a question for us, I have a question quickly for you.
Sure.
Being that you're in residency, med school, things of that nature, how often do you see a referral to physical therapy for the geriatric adult, or do you feel that it is underutilized, overutilized, or a misunderstanding of the abilities of a physical therapist? So I'm just curious. We get different ideas like, oh, we should send people to therapy more. We never thought of it. So I'm curious your schooling and your thoughts on the use of physical therapy for geriatric population.
On the inpatient population, we refer nearly every patient for physical therapy. Outpatient, it depends on the indication and whether we can get it paid for. That's
Okay.
getting adequate access to it, especially for patients who aren't on Medicare or Medicaid.
Okay. And do you have any type of general screen that you would do that would kind of fall out to PT, or do you just go by subjective assessment or assessment that you're doing on the patient, whether it need be or a fall or some type of change?
Pretty much any fall, any pain indication, those would all be indications for PT, and then the subjective debility assessment. I don't typically use the SLU debility scale, if that's what you're asking.
I was just curious if you had some type of assessment that you utilized to kind of assess either, you know, ability, functional ability, strength, anything of that nature.
Roughly use the get up and go, which
Okay.
is the patient's room in the outpatient setting, and then they're not right behind me in 5 seconds, then I just automatically put a
Okay. Great. And you'll see that a lot of facilities, a lot of facilities use the study program, which does include the timed up and go and a sit to stand type thing. So great. That's wonderful to hear. Thank you. Anybody else?
All right, I'm talking too much, but our group kind of has a consensus that we like you guys a little bit, kind of, sort of. Inpatient groups, a lot of us just rotate through internal med, and we saw PTs there every day. Some of us are in outpatient and family practice where we really don't see it that much. We all like you guys, we just don't know how to use PT services.
Mm-hmm. I think that is, I mean, that's common amongst many outpatient services, but I really think that if you feel somebody has decreased in function, somebody's decreased endurance, somebody feels like, you know, they're weaker, feels like they're not doing as much as they could, I think the real assessment would be for us to assess them and see if they're appropriate for therapy. And I think sometimes that's where you know, we have diagnoses that come over for anything from a specific diagnosis to, you know, pain, to feeling weak, to fear of falling, to any of those types of things. And I think then it's our assessment to know whether somebody's appropriate or maybe they just need community resources.
Yeah, this is Kelly, and I just flashed up the rapid geriatric assessment again. And the top 2 categories I feel like really can apply for helping to determine who should get referred to PT, even in an outpatient setting. So from a functional standpoint, if someone can't walk up a flight of stairs or 1 block, they should be referred. If they can't get out of a chair, somebody mentioned not right behind them. If a patient reports any falls, a near fall, a fall without an injury, those patients should be referred and allow the physical therapist to dig deeper into what might be contributing to that. But we all know that when you ask a patient, you know, have you fallen or how many times have you fallen, they often won't report or they'll underreport. So if someone reports any sort of a fall, my recommendation would be physical therapy without a question.
And I think in that realm, just remembering that when you ask about falls, a fall is not necessarily somebody who falls with injury. And a lot of patients interpret it that way. They say they haven't fallen because they didn't get injured. So a lot of times we'll ask, you know, have you fallen with or without injury, or have you slipped, or have you landed on the ground, you know, during any activity, just to kind of get an idea, because like I said, most aging adults don't like to admit falls or don't think they're falls if they don't have injury associated with them.
One more thing, I guess, thanks for asking this question. One more thing is that on the American Physical Therapy Association website, there's a feature where you can find a PT and you can look specifically for a geriatric clinical specialist, GCS, in your area. Now, there are only 12 of us in Missouri. So I'm not sure in your specific geographic area if there is a geriatric clinical specialist or not, but if you have a complex older adult and you're not sure maybe what's going on and you want a thorough geriatric PT assessment, I would look at the APTA, find a PT, and find a geriatric clinical specialist to refer them to. Good. All right, if there are no other questions, we'd like to thank you guys for your participation, and also thank AHEC for the opportunity to present with you. We will stick around for a few minutes if anyone does have any questions over the mic, or if you want to type in on the chat for questions. Thank you.
Yeah, thank you.